1. Mandibular resection, squamous cell carcinoma. A. Immediate postoperative rehabilitation. Surgical guide/resection appliance. Insert an intraoperative surgical splint or guide to maintain mandibular fragments in alignment. Intermaxillary fixation, IMF guiding flange. Apply temporary IMF or place an immediate mandibular guide flap/appliance to prevent deviation of the remaining mandibular segment toward the defect side due to unopposed muscle pull. PT Ergoids masseter. Soft tissue support and wound care. Provide extraoral and intraoral soft tissue support to minimize scar contracture and facial asymmetry. B. Instructions to the surgeon. Pre-prosthetic considerations. Preserve bony stock. Retain as much sound bone as possible, especially the mandibular symphysis and inferior border on the non-resected side, to preserve muscle attachments. Soft tissue management. Maintain an adequate depth of the vestibule. Avoid high muscle attachments or tight mucosal scarring near the defect zone. Attach gingiva. Preserve a wide band of keratinized attached mucosa over the remaining bony ridge for prosthetic load-bearing. Nerve and vessel preservation. Preserve the mental nerve on the non-resected side if oncologically safe to maintain sensory feedback. C. Definitive treatment plan. 1. Phase 1. Healing and training, 2 to 6 months. Fabricate a mandibular guide flange prosthesis, GFP, or palatal ramp prosthesis to re-educate muscles and guide the remaining mandibular segment into proper intercuspation. Physical therapy and mandibular guidance exercises. 2. Phase 2. Definitive prosthesis. Prosthetic selection, removable partial mandibular resection denture, or implant-supported, retained removable/fixed prosthesis, if free fibular microvascular bone flap reconstruction is performed. Occlusion scheme, non-anatomical or monoplane teeth, 0-degree lateral guidance, localized contact on the non-defect side to prevent dislodgement. Question 2. Congenital cleft palate and speech improvement. A. Indicated prosthesis. Speech aid prosthesis, palatal lift appliance or pharyngeal bulb velap obturator, depending on velopharyngeal function. B. Impression steps and materials. 1. Primary impression. Material, irreversible hydrocolloid, alginate, or high-viscosity impression compound. Step. Custom or modified stock tray. Cover defect area with gauze packing to prevent aspiration/engagement of undercuts. 2. Secondary/border impression, pharyngeal bulb portion. Material, low-fusing impression compound, green stick, or thermoplastic wax, Kerwax. Step. Custom acrylic tray with a wire extension extending into the pharyngeal area. The patient performs head movements, swallowing, speaking, turning head side to side, to functionally mold the bulb area. 3. Final wash impression. Material, polyether or light body addition silicone, PVS, for maximum detail accuracy. C. Assessment of effectiveness. Speech evaluation, resolution of hypernasality, nasal emission during vowels and pressure consonants like /b, b/b/p/p. Nace endoscopy/video fluoroscopy, direct visualization of the velopharyngeal sphincter closure against the bulb during phonation. Functional comfort, absence of nasal regurgitation during swallowing and fluid ingestion. Question 3. Post-insertion gagging reflex. A. Possible causes of gagging. Posterior extension issues. Overextended posterior palatal seal, PPS, area past the vibrating line onto the soft palate. Thickness and contour. Excessively thick posterior border of the maxillary denture base touching the dorsum of the tongue. Occlusal and vertical dimension. Excessive vertical dimension of occlusion, VDO, causing constant muscular fatigue/spasm. Lack of posterior occlusal stability. Loose denture. Inadequate retention causing the denture to drop/instability that triggers tactile mucosal gag reflexes. B. Areas to modify. Posterior palatal border. Trim length back strictly to the posterior vibrating line. Denture base thickness. Taper and thin down the polished surface of the posterior palatal border. Lingual flanges, mandibular. Reduce thick lingual borders that encroach on tongue space. C. Behavioral strategies. Desensitization and breathing exercises. Instruct nasal breathing techniques. Use rhythmic deep breathing exercises. Distraction techniques. Engage patient in conversation, count backwards, or elevate feet during insertion. Gradual adaptation. Timed wear schedules, e.g., 15 to 30 minutes daily, gradually increasing duration. Question 4. Kennedy Class 1 Mandibular Cast Partial Denture CPD. A. Investigations before treatment plan. Radiographic evaluation. Periapical OPG radiograph to assess root length, morphologic features, crown-to-root ratio, and periodontal ligament (PDL), space of abutment teeth, first premolars. Diagnostic surveying and mounting. Diagnostic cast surveying to identify path of insertion, guide planes, and contours. Mounted diagnostic casts on semi-adjustable articulator. B. Design elements of framework. Major connector lingual bar, or lingual plate if high floor of mouth, deep sublingual fold space less than 7 mm. Rest seats. Mesial occlusal rests on bilateral first premolars, RPI/RPA concept, to direct load vertically. Direct retainers, RPI system, rest mesial, proximal plate distal, I-bar clasp buccal, or RPA system on first premolars. Indirect retention. Canine rest seats or cingulum rests on anterior teeth positioned perpendicular to the fulcrum line. Denture base connector, meshwork/lattice design covering distal edentulous ridges with tissue stops. C. Functional movements and minimization. Movements. 1. Rotation around the fulcrum line, tissueward and tissue away. 2. Longitudinal rotation along the ridge crest. 3. Vertical translation/rotation around a vertical axis. Minimization techniques. Place mesial rests, RPI concept, to change rotation dynamics. Use indirect retainers as far anterior to the fulcrum line as possible. Perform altered cast impression technique to capture functional contours of the soft tissues. Question 5. Flasking, curing, and deflasking. A. Mold preparation, flasking. 1. First pour, lower flask half filled with dental plaster. Master cast embedded up to the dentureland area. 2. Separating medium. Apply cold mold seal/separating medium once plaster sets. 3. Second pour. Upper flask ring placed. Stone/plaster mixture poured to tooth level, exposing occlusal/incisal surfaces. 4. Third pour. Final capping with dental stone, lid secured. Dewaxing performed in boiling water bath, 4 to 5 minutes. B. Curing procedure. Packing. Heat cure PMMA resin packed in dough stage using trial closure technique with cellophane sheet. Polymerization cycle, long cycle. Water bath heated to 74 degrees Celsius. 165 degrees Fahrenheit for 8 hours, followed by boiling at 100 degrees Celsius for 1 hour. OR 74 degrees Celsius for 2 hours, then 100 degrees Celsius for 1 hour, short cycle. C. Next step and importance. Next step, bench cooling, followed by laboratory remounting. Importance, bench cooling. Prevents warpage, dimensional distortion, and internal stress buildup. Laboratory remounting. Corrects processing errors, occlusal discrepancies, and increased vertical dimension caused by resin expansion/flasking pressure. Question 16. Systemic complications and shallow ridge CD patient. A. Advisable investigations. Diabetic panel, HbA1c, fasting blood sugar, FBS, postprandial blood sugar, 2-HPPBS. Renal function test, serum creatinine, blood urea nitrogen, BUN, EGFR, serum electrolytes. Cardiovascular, blood pressure monitoring, ECG. Salivary assessment, flow rate/sialometry, due to complaints of dry mouth. B. Patient preparation. Medical clearance and stabilization of blood glucose, systemic blood pressure, and renal profile. Oral hygiene instruction and management of dry mouth using artificial saliva/salivary substitutes or frequent water sips. C. Special precautions during procedures. Short morning appointments to minimize stress. Use non-irritating, low-viscosity impression materials, e.g., zinc oxide eugenol or polyether with light pressure. Avoid sharp pressure on thin mucosal tissues to prevent mucosal tearing and ulceration. D. Special features of denture. Retention/stability. Maximum extension within anatomical limits. Use of salivary substitutes, moisturizers under the base. Relief and materials. Incorporate a resilient soft liner, long-term silicone liner, on fitting surfaces. Relief of sharp bony spicules, thin ridges. Occlusion, non-anatomical/monoplane or lingualized occlusion to reduce lateral displacement forces. Question 29. Burning mouth symptoms. Nasima Akhtar, 71 years. A. 3 relevant questions. 1. Does the burning sensation lessen or disappear while eating or drinking? 2. Do you experience dryness in your mouth or an altered/metallic taste? 3. Does the burning affect your sleep or do you wake up with it in the morning? B. Most probable diagnosis. Primary/secondary burning mouth syndrome, BMS, or denture stomatitis candida associated with localized glossitis. C. Important investigations. Candidal culture/cytological smear of the dorsum of tongue and inner surface of upper denture. Nutritional profile. Serum iron, ferritin, vitamin B12, and folate levels. D. Patient advice. Reassure the patient regarding the benign nature of the condition. Avoid irritating foods, spicy, acidic, or extremely hot foods/drinks. Maintain meticulous denture hygiene. Soak denture in antiseptic/antifungal solution. Do not wear denture overnight. Question 47. Kennedy Class II CPD design. A. Classification and support type. Kennedy classification, Kennedy Class II, unilateral edentulous area posterior to remaining natural teeth. Type of denture support. Tooth tissue-borne denture. B. Cross-arch stabilization and rationale. Is cross-arch stabilization provided? Yes. Rationale. Unilateral distal extension bases create strong rotational forces around the fulcrum line. Cross-arch stabilization distributes functional leverage forces to the contralateral side of the arch, preventing lateral displacement and tissue torque on the main abutment teeth. Quick reference, key definitive concepts. Lingualized occlusion, Q25. Maxillary lingual cusps articulate with mandibular central fossae. Eliminates buccal cusp contacts and eccentric movements. Indicated in severely resorbed ridges, Class 2/3 jaw relations, and soft tissue instability. Dean's alveoloplasty, Q22. Intraseptal alveoloplasty involving resection of interdental bone and collapsing of labial cortical plate inward. Preserves labial periosteal attachment and contour. Gothic arch tracing, Q12-Q20. Mechanical tracing technique used to record horizontal jaw relationships. The apex of the arrow point tracing indicates the initial contact position/centric relation CR. Where would you like to focus next? Solve all remaining short answer and theory questions. Here are the detailed, structured solutions for the remaining theoretical and short answer questions from your prosthodontics question bank. August 2022. Complete denture. 6. Occlusal planes and permitted movements. Occlusal planes. Sagittal plane, curve of Spee, anteroposterior curvature. Frontal/coronal plane, curve of Wilson, mediolateral curvature. Horizontal plane, occlusal plane parallel to the Camper's line, alatragus line, posteriorly, and the interpupillary line anteriorly. Permitted movements in each plane. Sagittal plane, protrusion and retrusion, anteroposterior translatory and rotational movements. Frontal/coronal plane, lateral excursion, working and non-working/balancing side movements. Horizontal plane, rotation around vertical axes during lateral excursive movements, Bennett movement and Bennett angle. 7. Midline fracture of complete denture and repair procedure. Causes of midline fracture. Stress concentration/fatigue along the midline notch, e.g., deep labial notch. Resorption of the alveolar ridge leading to flexure of the denture over a prominent hard palatal torus/mid-palatal suture. Inadequate thickness or poor polymerization of PMMA acrylic resin. Excessive impact force, dropping the denture on a hard surface. Severe occlusal disharmony or heavy anterior biting loads. Steps of repair procedure. Maxillary CD. 1. Assembly and sticky waxing. Align broken fragments accurately and secure them extraorally with sticky wax and reinforcing metal rods across the fracture line. 2. Pouring mastercast. Pour plaster/stone into the tissue surface of the assembled denture to form a repair cast. 3. Beveling/grooving. Remove the sticky wax, separate fragments, and bevel the fracture edges along the fracture line, 45 to the power of circ bevel, approximately 2 to 3 mm width on each side, to create a joint area, rabbet or V-shaped joint. 4. Applying separating medium. Apply cold mold seal onto the repair cast surface. 5. Autopolymerizing resin application. Alternately apply self-cure acrylic powder and liquid, salt and pepper technique, into the prepared fracture gap until slightly overfilled. 6. Curing. Place in a pressure pot at 20 to 30 psi in warm water, 40 degrees Celsius, 50 degrees Celsius, for 15 minutes to minimize porosity. 7. Finishing and polishing. Trim excess acrylic with burrs, smooth with pumice, and polish to high gloss. 8. Immediate denture, definition and comparison. Definition. A complete or removable partial denture fabricated for insertion immediately following the extraction of natural teeth. Comparison. Feature. Interim, transitional, immediate denture. Conventional, classic, immediate denture. Primary purpose. Short-term aesthetic/function, until tissue heals. Definitive long-term prosthesis, relining/rebase. Replaced or fully rebased after complete healing. Relined, tissue/hard reline, after bone remodeling. Surgical procedure. Posterior and anterior teeth extracted at same time. Posterior teeth extracted first, healed. Anteriors extracted at insertion. Cost and complexity. Lower cost, simpler procedure. Higher cost, precise laboratory step management. 9. CD stability, definition and improvement. Definition. The quality of a complete denture to resist displacement by functional horizontal, lateral, or rotational forces. Improving stability before fabrication. Pre-prosthetic surgical conditioning, e.g., bone grafting, alveoloplasty, vestibular extension, tuberosity reduction. Conditioning inflamed soft tissue with tissue conditioners. Improving stability after fabrication. Clinical occlusal adjustment/selective grinding to eliminate excursive interferences. Reline/rebase to restore tissue contact. Functional border molding/readapting overextended or underextended polished borders. 10. Special tray principles and palatal seal molding. Principles of special tray. Rigid and dimensionally stable, uniform 2 to 3 mm thickness. Smooth borders trimmed 2 mm short of the anatomical sulcus depth for border molding. Incorporates tissue stops, 3 to 4 locations, to ensure Yes, all 63 unique questions from your prosthodontics question bank, including all scenario cases, clinical
9. CD stability, definition, and improvement. Definition: the quality of a complete denture to resist displacement by functional horizontal, lateral, or rotational forces, improving stability before fabrication, pre-prosthetic surgical conditioning, for example, bone grafting, alveoloplasty, vestibular extension, tuberosity reduction, conditioning inflamed soft tissue with tissue conditioners, improving stability after fabrication, clinical occlusal adjustment, selective grinding to eliminate excursive interferences, reline rebase to restore tissue contact, functional border molding, readapting overextended or underextended polished borders. 10. Special tray principles and palatal seal molding. Principles of special tray: rigid and dimensionally stable, uniform 2-3 mm thickness, smooth borders trimmed 2 mm short of the anatomical sulcus depth for border molding, incorporates tissue stops, 3-4 locations, to ensure uniform impression material space, has a sturdy central handle perpendicular to the tray base, molding the posterior palatal seal area. 1. Locate anterior and posterior vibrating lines using phonation, R-sound, and Valsalva maneuver. 2. Apply low-fusing green stick compound across the distal border between the hamular notches. 3. Temper in warm water, seat in patient's mouth. 4. Ask patient to swallow, say ah, or pull nostrils while gently blowing, creating functional displacement of soft palate. 11. Compromising factors and treatment according to experience. Compromising factors in diagnosis: anatomical, severely resorbed ridges, flat vault palate, high frenal attachments, knife edge ridges, prominent tori, systemic, xerostomia, uncontrolled diabetes, Parkinson's disease, neuromuscular disorders, psychological, philosophical, exacting, indifferent, or hysterical mental classification, house classification, treatment options by denture experience, first time inexperienced denture wearers, conventional CD soft liners of fragile mucosa, extensive adaptation phonetic orientation, experienced satisfied denture wearers, copy duplicate existing dentures to retain familiar occlusal schemes and borders, unsatisfied difficult adaptability wearers, implant retained overdentures, neutral zone technique, or lingualized monoplane occlusal schemes. 12. Tracing plate findings and face bow transfer. Findings on Gothic arch tracing plate. Apex of the arrowhead represents centric relation CR, initial, retrusive position, limbs of the arrowhead, right and left lateral excursive movements, center line, if present, straightforward protrusive path. Procedure to transfer face bow record to articulator. 1. Secure the face bow assembly onto the articulator mounting frame condyle guidance assembly, using the face bow adapter or bite fork support. 2. Align the elevated front pin's incisal pin to 0 baseline. 3. Place the maxillary cast firmly into the bite fork impression registration. 4. Secure the upper member of the articulator and attach the maxillary cast using mounting plaster. 13. Arranging maxillary anterior and mandibular posterior teeth. Maxillary anterior teeth arrangement. Central incisors, incisal edge 8-10 mm anterior to the center of the incisive papilla, parallel to interpupillary line. Midline aligned with facial midline. Lateral incisors, elevated 0.5 to 1.0 mm off the occlusal plane. Neck necked and distally. Canines, tip touches the occlusal plane. Neck prominent canted out. Distal slope points toward the center of the posterior ridge. Mandibular posterior teeth arrangement, positioned centered strictly over the crest of the mandibular ridge, Pound's line, occlusal plane set at the junction of the middle and upper third of the retromolar pad. Sequential arrangement, first premolar, second premolar, first molar, second molar maintaining correct intercuspation with maxillary counterpart. 14. Single complete denture, challenges and complications. Challenges in fabrication, severe force generated by natural teeth against the edentulous opposing ridge, irregular, malposed, or extruded opposing natural teeth creating traumatic occlusal planes, rapid resorption of the edentulous arch. Complications, combination Kelly syndrome, loss of bone from the anterior part of the maxillary ridge, epulis fissuratum in the labial vestibule, papillary hyperplasia of the hard palate mucosa, extrusion of mandibular anterior teeth, severe posterior mandibular ridge resorption. 15. Modillus and its importance. Definition: a chiasma fibromuscular hub located lateral to the corners of the mouth, buccal to premolars, formed by the convergence of 8 facial muscles, for example, Orbicularis oris, buccinata, levator anguli oris, zygomaticus major, rosorius. Importance in CD fabrication. Polished contour, controls the labial and buccal flange width. Thick denture borders at the modulus cause dislodgement during facial expression mastication. Premolar arch width, constricts the premolar region arch width to prevent muscular displacement. Occlusal plane height, helps define the height of the occlusal plane. Must lie at or below the narrow corner of the mouth to ensure muscle action stabilizes rather than unseats the denture. February 2025. Unique questions. 19. Stress-bearing areas in maxilla and importance. Primary stress-bearing areas. Maxilla. 1. Firm posterior hard palate, horizontal hard palate lateral to the midline. 2. Posterior alveolar ridge slopes. Secondary stress-bearing areas. Maxilla. 1. Crest of the edentulous alveolar ridge, especially if resorbed mobile. 2. Maxillary tuberosities. Importance. Directs masticatory loads onto dense cortical bone covered by resilient submucosa, preventing accelerated bone resorption, mucosal injury, and loss of retention. 20. Locating eye-centric relation on Gothic arch tracer. Technique. 1. Attach the central bearing plate to the maxillary rim and tracing pin to the mandibular rim. 2. Instruct the patient to perform mandibular movements, protrusion, right and left lateral excursions until a clear, sharp apex arrowhead pattern is scribed. 3. The exact apex of the arrowhead corresponds to centric relation CR. 4. Place a clear plastic disc with a drilled recess over the apex and fix it in place with sticky wax. 5. Have the patient close so the tracing stylus drops into the recess at CR. Then inject quick setting bite registration material between the rims. 21. Speaking and phonetic assessment in tooth arrangement. Phonetic tests. F and V sounds, fricatives. Maxillary incisal edges should lightly touch the wet-dry line of the lower lip. S or Z sounds. Sibilance. Evaluates the closest speaking space, Silverman's space, normally 1-2 mm between anterior teeth. If teeth click, vertical dimension of occlusion, VDO, is excessive, then TD sounds. Tongue tips should touch the palatal surfaces of maxillary anteriors without blocking airflow or protruding excessively. 22. Prosthodontic indications and Dean's alveoloplasty. Indications of alveoloplasty. Sharp, irregular bony prominences or undercut ridges preventing denture seating. Severe labial undercut prominence interfering with aesthetics or insertion path. Inadequate inter-arch distance due to bony overgrowth. Steps of Dean's intraseptal alveoloplasty. 1. Reflect a minimal mucoperiosteal flap along the crest of the ridge. 2. Remove interdental bone septa using rongeurs or burrs. 3. Cut a V-shaped trough in the interradicular bone. 4. Fracture the labial cortical plate inward using thumb pressure. 5. Smooth sharp edges with a bone file, irrigate, and suture the flap margins. 23. Management of severely resorbed ridge. Techniques and modifications. 1. Impression technique. Functional dynamic impressions, for example, admix technique or soft tissue conditioning impression. 2. Neutral zone concept. Record the muscle-free space bounded by tongue and cheeks to shape the polished surfaces and place teeth. 3. Occlusal scheme. Use non-anatomical, 0-degree, or lingualized occlusion to reduce lateral tipping forces. 4. Base and liners. Soft resilient silicone liner on the fitting surface to absorb shock. 24. Vertical dimension tests and parallelism of ridges. Tests for establishing correct VDO, physiologic rest position, VDR, freeway space, phonetic method, Silverman's closest speaking space, facial aesthetics proportions, distance from eyebrow to nose versus nose to chin, swallowing threshold method, importance of parallelism of ridges, ensures uniform distribution of occlusal forces across both ridges during closure, prevents slippage forward sliding forces on the denture bases. 25. Lingualized occlusion concept and indications. Concept. Maxillary anatomical semi-anatomical lingual cusps contact flat or shallow concave anatomical surfaces of mandibular teeth. Buccal cusps of maxillary teeth are lifted out of occlusal contact. No lateral interference. Indications. Severely resorbed alveolar ridges, Class 2 and Class 3 maxillomandibular relationships, displaceable flabby soft tissue ridges, priority for high masticatory efficiency with lateral stability. 26. Evaluation of occlusion rims, before insertion, lab bench, flat, smooth wax surface, Correct dimensions: maxilla, 22 mm height anteriorly, 8-10 mm width posteriorly. Mandible, 18 mm height anteriorly. Basiplate stability and smooth rounded borders. After insertion, in mouth. Lip support and lip line. Upper rim supports upper lip naturally. Anterior wax edge visible 1-2 mm below lip line at rest. Parallelism. Maxillary rim parallel to interpupillary line anteriorly, and Kemper's line posteriorly. Midline and canine lines. Correctly marked on wax surface. 27. Long-term soft liners. Indications and ideal requirements. Indications: severe alveolar ridge atrophy with thin, sensitive submucosa, knife edge ridges and prominent, unoperable bony spicules. Chronic denture sore mouth, intolerance to hard acrylic. Ideal requirements: high permanently elastic resilience without hardening over time. High bond strength to PMMA base, no debonding peeling. Non-toxic, non-irritating, low water absorption, biostable, and resistance to fungal, candida, colonization. 28. Importance and ideal characteristics of articulators. Importance: allows diagnosis and arrangement of teeth extraorally, under functional conditions, eliminates patient saliva, muscle movement, and tissue elasticity factors during adjustment, permits precise replication of lateral and protrusive excursive movements. Ideal characteristics: maintains exact vertical and horizontal registration settings indefinitely, accepts Facebook transfer records, adjustable condylar elements, incisal guide table, and rigid non-flexing construction. 30. Relief areas, orientation, jaw relation, and age impact. Areas to relief: 1. Incisive papilla. 2. Midpalatal suture torus palatinus. 3. Sharp bony ridges spicules. 4. Mental foramen, in severe lower ridge resorption. B. Steps in recording orientation jaw relationship. 1. Locate and mark anterior and posterior anatomical landmarks. For example, external auditory meatus, infraorbital notch. 2. Apply bite fork with registration wax onto the upper rim. 3. Align and tighten face bow frame to the patient's face, ibocondyle pins, and infraorbital pointer. 4. Lock the assembly, remove intact, and transfer to the articulator. C. Impact of age on edentulous patient. Reduce salivary output, dry mouth, loss of retention, mucosal atrophy, delayed tissue healing, and muscular incoordination. 31. Irritation and burning sensation after CD insertion. Investigations and examinations. Intraoral inspection for pressure spots, ulceration, or candida, erythematous patches. PIP pressure indicating paste. Test under denture base. Evaluation of VDO. Checking for excessive VDO. B. Possible causes: excessive vertical dimension of occlusion, lack of freeway space, residual monomer toxicity from incomplete acrylic polymerization, direct nerve compression, for example, pressure on incisive papilla, or mental nerve. C. Advice and instructions: leave denture out at night. Warm saline rinses. Return for selective pressure spot relief and occlusal re-equilibration. D. Alternative treatment options: hypoallergenic denture material, for example, light-cured resin, or injection-molded nylon polycarbonate base. Remounting and reduction of VDO. 32. Checklist for teeth alignment on articulator. Anterior teeth evaluation. Frontal view. Alignment with facial midline. Symmetry of central incisors and smile line curvature following lower lip contour. B. Checklist for angulations. Occlusal view. Teeth follow the horseshoe line of the ridge crest. Incisal edges and cusps aligned correctly along the parabolic arch line without crowding. C. Overbite and overjet observation. Overjet, 1-2 mm horizontal clearance. Overbite, 1-2 mm vertical overlap. Minimize to prevent tripping during excursive movements. August, 2025. Short answer and scenario questions. 33. Bench curing. Definition and objectives. Definition: allowing the packed acrylic flask to rest undisturbed at room temperature for 30 to 60 minutes before placing it into the heat-curing water bath. Objectives: 1. Ensures uniform equalization of pressure across the mold space. 2. Allows full penetration dissolution of monomer into polymer particles for a homogeneous mix. 3. Releases internal stress trapped during trowel closure, reducing warpage. 34. Occlusal schemes in complete denture. Types of occlusal schemes. 1. Anatomical balanced occlusion. Teeth simultaneous contact in centric and eccentric positions, used in good ridges. 2. Non-anatomical monoplane occlusion, flat teeth, no incline planes, minimizes lateral vector forces on flat ridges. 3. Lingualized occlusion, maxillary functional cusps articulate with shallow mandibular fossae, merges stability with masticatory efficiency. (35) Static impression, definition and situations. Definition: an impression recorded with minimal or zero pressure applied to the underlying mucosal tissues. Mucostatic concept: preserving tissue in its undisturbed rest state. 3 situations for used. 1. Highly displaceable flabby ridges. 2. Atrophic, thin, fragile oral mucosa prone to ulceration. 3. Patients with compromised tissue healing capacity. For example, radiation therapy recipients. 36. Mandibular CD insertion checklist and challenges. Checklist before insertion: absence of sharp surface irregularities or acrylic flash on the fitting surface, smooth, rounded, polished borders, relief provided over lingual undercuts. Why mandibular denture fitting is challenging: smaller load-bearing area compared to maxilla versus dynamic movement of the tongue and floor of the mouth constantly disturbing peripheral seal, advanced rate of bone resorption in the lower arch. 37. Pre-prosthetic surgery and surgical procedures. Definition: surgical procedures performed prior to prosthetic construction to modify, preserve, or reconstruct oral structures for optimal denture support, retention, and stability. Surgeries improving denture-bearing area. 1. Frenectomy, labial-lingual. 2. Vestibuloplasty, deepening of sulcus. 3. Excision of epulus fissuratum hyperplastic tissue. 4. Ridge augmentation, bone grafts distraction osteogenesis. 5. Reduction of maxillary tuberosities and reduction of tori. 38. Relationship of tooth to cast and compensating curves. Relationship to cast: posterior teeth must be positioned directly over the crest of the ridge to channel vertical loads efficiently without tipping the denture, incorporating compensating curves. Curve of Spee, anteroposterior, elevating the distal cusps of lower molars upward. Curve of Wilson medialateral, inward lingual tilting of mandibular, posterior teeth, prevents Christensen's phenomenon posterior tooth separation during protrusion. 39. Final forming guidelines for maxillary occlusion rim and inadequate lip support. Clinical guidelines: 1. Anterior height 22 mm from sulcus depth. 2. Labial surface supports upper lip restoring nasolabial angle. 3. Parallel to interpupillary line anteriorly. Consequences of inadequate lip support: thinning and collapse of upper lip, deepening of nasolabial folds, and premature facial aging appearance. Excessive exposure of upper wax rim or acrylic base. 40. Neutral zone concept and muscle action. Concept: the potential space in the mouth where forces exerted by the tongue outwards are equalized by forces exerted by the cheeks and lips inwards. Role and height of occlusive plane instability. Placing artificial teeth within this neutral zone prevents tooth destabilization during swallowing, speaking, and mastication. Setting occlusal plane height level with the neutral muscular equilibrium point prevents tongue or cheek entrapment. 41. Causes and prevention of complete denture fracture. Causes: high impact drops, deep labial frenal notches concentrating stress, flexure fatigue over an unrelieved midline hard palatal torus. Preventive factors: adequate acrylic thickness, 2 mm, along stress zones, provision of stress relief over bony prominences, incorporating high impact resins or mesh fiber reinforcement. 42. Facebow and articulator short notes. Facebow: a caliper-like device used to record the spatial position of the maxillary arch relative to the temporomandibular joints, transverse horizontal axis, and transfer this relationship to an articulator. Articulator, a mechanical instrument that represents the TMJs and jaw members, to which maxillary and mandibular casts are attached to simulate jaw movements. 43. Pain posterior to maxillary tuberosity. A denture fault, overextension of the posterior palatal border, beyond the hamular notch vibrating line, or overpressured border molding in the pterygomaxillary notch area. C. Impression recording technique. Use low viscosity light body elastomeric material with minimal pressure. Carefully carve and trim the custom tray 2 mm short of the hamular notch prior to border molding. Group B. Scenario and theoretical questions. 44. Middle old population and prosthetic options. Age range and challenges. Age range, 75 to 84 years. Middle old. Challenges, reduced neuromuscular control, brittle fragile mucosa, xerostomia, systemically compromised systemic conditions, impaired psychological adaptability. B. Prosthetic options before completely edentulous. Tooth-supported or root-supported overdentures. Removable partial dentures. CPD acrylic. C. CD options when edentulous. Implant retained two-locator overdenture. Conventional CD with resilient soft liner and neutral zone arrangement. 45. Wear and dislodgement case. 5 years wear. How it happens. Severe attrition of acrylic resin teeth over time combined with continuous ridge resorption, leading to loss of vertical dimension, lateral sliding, and an edge-to-edge occlusal discrepancy. B. Treatment plan. Fabrication of a new set of complete dentures. C. Performance. Re-establish correct vertical dimension of occlusion, VDO, and centric relation CR. Select wear-resistant porcelain composite teeth, and construct a balanced occlusal scheme. 46. 14-day infant with bilateral cleft palate. A. Prospective treatment plan. Pre-surgical nasalveolar molding NAM. Feeding obturator appliance. B. Multidisciplinary team members. Pediatric dentist, prosthodontist, oral and maxillofacial surgeon, plastic surgeon, orthodontist, speech pathologist, pediatrician. C. Impression procedure. 1. Performed in a fully equipped clinical setting prepared for airway management. 2. Infant held in an upright prone position. 3. Heavy body silicone putty or elastomeric material used in a custom tray to avoid aspiration. 48. Kennedy Class 1 mandibular CPD with bilateral missing molars. Components and justification. Major connector, lingual bar or lingual plate, for structural rigidity. Rests, mesalocclusal rests on first premolars, reduces tipping leverage. Direct retainers, RPI system, rest, proximal plate, I-bar, to release stress during functional tissue displacement. Indirect retainers, canine premolar rest seats anterior to fulcrum line. C. Functional movements and minimization. Movements, rotational movement around the fulcrum line, tissue ward displacement, and vertical lifting. Minimization, use of indirect retainers, mesial rests, altered cast impression techniques, and broad coverage of the distal extension base. 49. Complete denture dislodgement during protrusion. A. Cause of dislodgement, lack of compensating curves, Christensen's phenomenon leading to posterior tooth separation without balanced contact, or an overextended distobuccal flange. B. Denture design and severe ridge resorption. Neutral zone tooth arrangement, lingualized or 0-degree occlusal pattern, resilient tissue liner base. C. Retentive factors, adhesion, cohesion, interfacial surface tension, muscular control, capillary attraction, and anatomical border seal. 50. Denture cleansing and disinfection. A. Commonly available denture cleansers, alkaline peroxides, effervescent tablets, dilute sodium hypochlorite, chlorhexidine rinses, enzymatic cleansers. B. Disinfection procedure. Soak denture in sodium hypochlorite solution or glutaraldehyde solution for 10 to 15 minutes. C. Properties of ideal denture cleanser. Non-toxic, non-corrosive to metals PMMA, bactericidal and fungicidal, easy to use, leaves no unpleasant odor taste. 51. Occlusion rim guidelines and dimensions. A. Guidelines must strictly sit centered over the crest of the alveolar ridge, with flat polished borders and defined heights. B. Forms and dimensions. Maxillary rim, anterior height 22 mm, posterior height 8-10 mm, width 4-6 mm anteriorly, and 8-10 mm posteriorly. Mandibular rim, Anterior height 18 mm. Posterior height flush with height of retromolar pad. C. Functions. Establish, VDO-VDR, record-centric orientation relation, transfer lip support, and determine tooth selection bounds. 52. Complex maxillary edentulous and compromised anteriors.
Treatment plans and theoretical short answer questions have been fully solved and structured. Here is a quick overview of what has been covered.
'53. Generalized denture stomatitis case. Diagnosis: Candida-associated denture stomatitis, type 2/3, confirmed via cystological smear-countable culture. B. Management: topical antifungal therapy, nystatin suspension or miconazole gel, removal of ill-fitting denture, tissue conditioning treatment. See patient advice. Leave denture out at night. Clean daily with cleansers. Store in dry environment overnight. Avoid overnight wear. July 2025, Group A. 54. Maxillofacial stent, splint, and radiation prosthesis. Maxillofacial stent, a device used to support, hold, or position tissue grafts or structures during surgical healing. Maxillofacial splint, a device used to immobilize, align, or stabilize fractured or resected osseous structures. Functions of radiation prosthesis. 1. Position healthy tissues away from the primary radiation beam path. 2. Shield vulnerable tissues with lead lining. 3. Hold carrier tubes for brachytherapy sources. 55. Sleep apnea and management. Definition: a sleep disorder characterized by repeated cessation of airflow breathing for 10 seconds or longer due to upper airway collapse or central neural loss. Management: 1. Continuous positive airway pressure, CPAP, therapy. 2. Oral appliances, mandibular advancement devices, MAD, or tongue retaining devices, TRD. 3. Lifestyle modifications, weight loss, sleep positioning. 56. Occlusal schemes for severely resorbed ridge. Schemes: lingualized occlusion, non-anatomical, monoplane occlusion, or dynamic neutral zone setup. Rationale: minimizes destabilizing horizontal and tipping forces during excursive movements, keeping force vectors strictly vertical over remaining bone stock. 57. Pre-prosthetic versus prosthetic mouth preparation. Pre-prosthetic preparation: surgical or hard soft tissue procedures performed before impression making, for example, frenectomy, alveoloplasty, bone grafting. Prosthetic mouth preparation: mechanical alterations performed directly on natural abutment teeth, for example, rest seat preparation, guide plane preparation, dimpling. Importance: establishes a non-interfering path of insertion, distributes functional loads along tooth-long axes, and eliminates undercut retention hazards. 58. Cingulum rest seat configuration. Configuration: V-shaped or inverted crescent-shaped notch prepared on the lingual cingulum surface of anterior teeth, canines incisors. Armamentarium: inverted cone diamond burr or tapered round-ended carbide burr. 59. Candida stomatitis. Factors and prevention. Predisposing factors: continuous overnight denture, wear, poor oral hygiene, dry mouth, xerostomia, immunocompromised status, uncontrolled diabetes. Prevention: regular daily denture cleaning with disinfectant solutions, taking dentures out overnight, maintaining oral hygiene, and managing systemic conditions. 60. Pickup impression technique. Description: an impression technique used for distal extension partial dentures, Kennedy Class 1 and 2. Steps: 1. Fabricate framework and fit it accurately to teeth. 2. Attach impression trays to the framework grid. 3. Record functional ridge impression under load, altered cast. 4. Seat framework in mouth and take an overall pickup impression over the entire arch, using alternate elastomer to pick up both the framework and the surrounding arch elements simultaneously. 61. Mechanical physiological VJR methods and phonetic test. Mechanical methods. 1. Pre-extraction records, profile photographs, articulated casts. 2. Ridge parallelism. 3. Distance from incisive papilla to lower incisors. Physiological methods. 1. Rest position measurement, VDR. 2. Swallowing threshold. 3. Phonetic test, Silverman's closest speaking space. Phonetic test description. The patient counts from 60 to 66 or repeats words with S sounds while the clinician observes the clearance between occlusion rim's teeth. Space. 62. Reasons for clasp arm breakage. 1. Metal fatigue. Repeated flexing beyond the proportional limit of the alloy during placement and removal. 2. Work hardening overbending. Structural weakening caused by excessive manual adjustment using pliers. 3. Floor's structural porosity. Internal casting defects or uneven thickness created during laboratory's processing. 63. Velopharyngeal closure mechanism and disruption. Mechanism. Sphincteric closure achieved by the upward and backward movement of the soft palate. Levator veli palatini. Meeting the forward movement of the posterior pharyngeal wall superior pharyngeal constrictor Lallemant's ridge. Disruption factors. 1. Anatomical defects. Unrepaired cleft palate. Tissue loss post-oncologic resection. 2. Neuromuscular deficits. Palatal paralysis. Stroke. Cerebral palsy leading to velopharyngeal insufficiency. VPI.